to talk about how we optimize hypoglossal nerve stimulation and within the greater context, really, of the sleep surgery approach. Just to really hypoglossal nerve stimulation, very exciting, a new um, modality of intervention for sleep apnea. But really, I think if we put it within the context of everything else that we already know about sleep surgery, I think a lot of this can be optimized. And I'm also especially excited that it seems like in the near future, this will be introduced in Asia and in Hong Kong. I have no relevant disclosures. Um, yes, this is where I work. I do direct the sleep surgery fellowship, and I look forward to connecting with all of you. There's no secret. I miss all of you in Hong Kong, and I've had the good fortune to make several trips out there to even operate with you. Again, very much appreciate our continued collaboration there. For today, in the brief 20 minutes, I want to go through just very quickly the outline. So we'll again remind ourselves, what is the mechanism of OSA that we can treat as surgeons. I want to go through, the selection criteria for hypoglossal nerve stimulation, which in the U.S., the only FDA-approved device is the Inspire device. But can we expand this criteria? Is there a way that we can bring more patients who take them so that they can fulfill the selection criteria? I'll talk a little bit about surgical techniques and their evolution, and even in the brief 6 to 7 years that we've been doing this clinically, much has changed. And then we'll talk about improving the outcome, especially on the level of titration of the device. And I think I want to end with some key concepts, in terms of key considerations. What is the role of optimizing nasal breathing during sleep and why that matters? Why lateral pharyngeal wall and oral pharynx collapse is a problem, and what can we do to circumvent that? And finally, of course, I want to try to throw a curveball to all of this so that because again, it's ongoing research. There's still so much to learn. These are, generally the four main mechanisms of OSA pathogenesis that we often cite. And for the time being, really important to remember that, the negative pressure that's required to close the airway is what, as surgeons, we can treat. And whether you're doing tonsil, soft tissue, skeletal, hypoglossal, CPAP, anything that we do, we are trying to change upper airway collapsibility measured by, as I had just mentioned, PCRIT. This happens to be a patient before and after maxillomandibular advancement, but this is our common goal, right? We want the patient to sleep with the airway stable. As I often describe this with a cartoon in clinic for patients, the whole system has to work, right? The whole system has to work together in order for that to happen. And what I mean by that is we'd like the patients to breathe nasally during sleep. Tons of benefits for that. We could talk at length about it. But when we do so, there is negative pressure that will collapse the upper airway muscles, right? And these are the upper airway dilator muscles that's supposed to counteract that force of negative pressure, and that is supported by the jawbone. And today, more specifically, we'll talk about powering the key dilator muscles of the genioglossus and geniohyoid. But having that big picture in mind, it's important to note that is why when this therapy works, even though it enacts upon the tongue and acts upon the genioglossus muscle, the whole thing has to work, right? So the lateral pharyngeal wall, via the transmission of forces from the tongue all the way up to the velum, this whole system has to work in order for the patient to have a satisfactory therapeutic response. And where does it lie then within this greater Stanford sleep surgery algorithm? Again, it is, as I stress, part of it. It is important, but in order for it to work, the entire airway has to open. At the same time, it also means that everything else that we already do and we already know about sleep apnea surgery can be put together appropriately to maximize, right, the mechanism of action for any of these interventions. So very briefly, I think a lot of you are already very familiar with how this works, but just to go over this quickly again, The idea is that in the identification of medial branches of the hypoglossal nerve, which powers the genioglossus and geniohyoid, we're able to selectively, bring the tongue forward. And this is, the action. This occurs at the end of the expiratory phase, just before the patient breathes again, where the most negative pressure is produced. Now, you'll look at this cartoon. I made it probably this is only about a year and a half, maybe 2 years ago, I forget. But you'll see that, it has a stimulation lead here. Here's the battery, the IPG, and a lead down to the respiratory sensor. So even this respiratory sensor, I'll go over this in a little bit. We've been able to evolve to a 2-incision technique to reduce, basically additional surgical sites. One of the key selection criteria is that we'd like the patient to have a BMI less than 32. And while not an absolute contraindication, the AHI response is certainly lower as the patient, as we have a higher BMI. And as you know, with higher BMI, you have adipose tissue deposition in the lateral pharyngeal wall and at the tongue base. The other very, very key selection criteria is to select against complete concentric collapse of the velum. So something that looks like that, okay? And, from the very beginning, we thought, what we can do is, stage it. We could do a palate surgery, right? A tissue preserving palate surgery, and convert what is a concentric collapse to, say, anterior posterior collapse. And then thereby the patients will then be, will be expected to fulfill the criteria and have a better outcome with upper airways stimulation. One thing that is kind of interesting in the US is, in this series that I published, 2 of them after palate surgery ended up having AHI less than 15, and that could frequently, happen, except that the AHI of 15 to 65 is the range of AHI criteria also for upper airway stimulation. So when you're less than 15, you actually cannot get upper airway stimulation surgery. Now, briefly to review this, so and we did this in Hong Kong with Natalie and team. But the idea is we don't want to do a very aggressive pharyngoplasty at all, because this is not the only tool in our toolkit. And if we're preparing, remember, we're preparing a patient for upper airway stimulation. If we do a lot of aggressive surgery to these key dilator muscles, you're going to mess up the communication between the tongue and the soft palate, which is really key. So for us, after removal of tonsils, what we do is we just anchor the more floppy muscle, right, to the more stable dilator muscles. So we go from palopharyngeus to paloglossus and levator to the palopharyngeus. This action lateralizes the soft palate region, and then we follow it up with a suture from the tensor down to the palopharyngeus, and that actually advances the soft palate. And so that's it, 3 sutures on each side, and that's all we need to do, right? Because all we're trying to do very conservatively, right, is we want to change, right, this from a pattern of concentric collapse, and also then allow all of these dilator muscles to be intact for their functions to work with the assistance of upper airway stimulation. Now, in terms of surgical techniques and evolution, you'll see that again, this is the old, right? The 3 incisions technique, and this is of the stimulation lead. This is now something that we don't need to do anymore, and that is great from multiple different angles. What remains important is the monitoring via the NIMS monitor as we select branches that retract the tongue versus those branches that advance the tongue. We like collaborative viewing. So some people use the microscope. I like the Vitom scope, just easy to set up. And we get a really nice view of the nerve branches as we stimulate and identify the nerve branches that we want to put the cuff around. So the 2-incision implant, I think my good friend, this is published by my good friend, David Kent. And I think this is really something that folks learned as we were doing these for the pediatric population under a clinical trial, for patients with Down syndrome. Okay, but the idea is, where we make this incision to place the IPG, to place the battery, we also then place a sensing lead basically in the second intercostal space. So we just kind of loop it around and then insert it there. So we don't have to make that incision down at the lateral chest wall. So that's really nice. So this is, again, this is what we used to do. We would come down to the intercostal muscles, basically lateral to use the serratus, and then we would, put the sensing lead between the external and internal intercostals. Okay, this is this is a little bit edited and a little bit speeded up, if you will, but this is how we do the procedure today. So where you're looking at, right side of the neck, incision is anterior to the submandibular gland. You see that to your upper left, and the digastric tendon, we retract it more inferiorly, and then the medial retractor, that's retracting the mylohyoid anteriorly. And this is, of course, sitting all superficial to the hypoglossal muscle. You frequently encounter the Rainen vein, which in this case here we took it, and right underneath is where you find the main branch point of the hypoglossal nerve. So there we are. And once that is identified, we'll put a vessel loop around it. And that's where this goes back to the NIMS monitor that were placed. Remember that there's one that inserts down to the genioglossus and geniohyoid, and then one that's inserted through the side of the tongue, trying to, monitoring for the stylo and the retractor muscles. Okay. So here, and again, this is where we're testing. So lateral branches are going to be the exclusion branches. Medial branches are the inclusion branches. And you'll note there's the C1 is included in that bundle. So here we are with the stimulation lead. This has 3 electrodes. You'll see that that's what those 3 little metallic looking things are. So we can titrate the polarity. We can titrate the voltage upon which we stimulate this nerve. And then here, you're actually now looking at the chest. Okay, so the right upper chest, second intercostal space. And through here, we'll then dissect through the external intercostal and insert the stimulation lead. It's interesting. It's one of those things where you're like, why didn't we do that in the first place? And again, a lot of this is historical. There were, similar devices. Obviously, neurostimulation has, had years of development. And it's one of those things where, as we folks, and I take no credit on this one, but as folks are doing more and more of these, we're like, you know what, this is probably a good idea. And it indeed is. So, because what you'll see is it avoids one extra tunneling for this lead, okay? Now, the Inspire system works with this closed loop where, again, as I mentioned, at the end expiratory phase, right before the patient takes a breath, that's when the stimulation fires, okay? All right, so that's generally the placement of the sensing lead. Okay, so right in the old days, we'd have to tunnel the sensing lead, right, from the lateral chest wall up to the IPG pocket. Okay, so now this step we don't need to do anymore. We still need to do this step, which is going from the neck subplatysmal plane down to the IPG pocket. Now, this battery supposedly has a shelf life, let's say, of 10 years or so. And even in the last couple of years, this thing has evolved so that it is somewhat MRI compatible. It is compatible for the head and extremities MRI with very specific coils. Okay. All right. Very nice things about this therapy is that we can confirm stimulation. So you can see the tongue fully stimulated, pushing forward a little bit to the left as we turn up the voltage. So that's good. Again, another better view of this unhindered protrusion of the tongue. You also notice that the tongue, intrinsic tongue muscles work so that it curls. This is also why, if this is ideal for the airway, you probably want to walk away from doing midline glossectomies because you're going to create a lot of scarring and you're going to kind of lose that intrinsic muscles of the tongue function. We take an X-ray immediately post-op, of course, to rule out pneumothorax. And this is again of the old, where this goes down here. And now with the new 2-incision technique, the battery is here. And then the sensing leads loops around and in the second intercostal space. So very nice. In an ideal world, about 2 to 3 months later, patient comes back, we titrate the implant so that we get a picture this good. I would say probably at least half of the patients require some degree of titration afterwards. In terms of now, once a good threshold is found, once a good stimulation threshold is identified, tends to be that at least we're not seeing a need to change this a whole lot in the long run. There's no gender differences that's discernible, and again, some elder patients seem to require initially a higher functional threshold, but again, seems to have very good long-term stability. You're not having to titrate it all the time. That being said, titration, from my early years, I've actually, titrated it with awake or sleep endoscopy, because we want to really see, right, how the tongue is, and the rest of the upper airway is responding to the therapy. My good friend Raj compared an endoscopic view of the titration versus just having the patient mouth open, okay, and looking at tongue movement. What is quite interesting, actually, in terms of what they found was that, with awake endoscopy, okay, how much the stimulation moves the tongue base seems to correlate well with reduction of AHI, versus when you have the patient mouth open, it doesn't, work as well. And in fact, not seeing too much tongue movement seems to correlate better. But I think, based on what I observe in clinic, it's probably because if you're able to see a full motion of the tongue in transoral, meaning just open mouth observation, that stimulation is very, very stimulating. Okay, it'll wake you up during sleep. So additional considerations, right? I think we can never, ever, ever, ever forget nasal breathing during sleep and how important that is. Okay, so internal nasal valve resistance, right, accounts for up to 50% of upper air resistance. A lot of ways we treat this, of course, and during the day, during when the patient's awake, this is fine. We do the surgery, but remember that when the patient's asleep, the demands are even higher, right? Because we're going to breathe through the path of least resistance. So we treat inferior turbinates. Don't forget, posterior nasal obstruction counts for at least 25% of people who don't tolerate well to CPAP therapy, which likely means they won't tolerate well to upper airway stimulation either. We do ASRs. Don't forget septal body, upper lateral cartilage stabilization, whether you like to do just a simple suspension, versus, spreader grafts. These are all really important to do. And they really will improve not only sleep quality, but the outcome of a lot of our measures. But I really, let's not forget, right? Also, part of the internal nasal valve is the nasal floor or the palatal roof. And patients who are narrow like this are going to have a tough time because during sleep, right, the tongue has nowhere to go. And so the patient's going to have their mouth open. There's going to revert to mouth breathing. And the instability of the lower jaw is going to make titration of your hypoglossal impossible. Because right now it's not like APAP, where the degree of voltage and stimulation changes according to the need or the demand of the moment. You want to be as stable as you possibly can. So we still favor the dome-shaped palate. We introduced this technique with Natalie in Hong Kong, and this is not something to forget, because if you're asking the tongue to move inside the mouth, there has to be room inside the mouth, and the patient still needs to breathe, all right, nasally. So dome expands the internal nasal valve, decreases the negative pressure. These are all very, very good things. And most important thing is patient response is key, and they do report a much better nasal breathing. This was at the Prince Wales Hospital, wonderful experience, and just for the folks who were there with us. And we've evolved the dome to an endoscopic technique with guides, and so it's even less invasive than before, and more the reason to do it. But this is what I'm trying to say: if this is what the tongue is doing during sleep, your patients are much more likely to have a better outcome if that's what they look like, right? And so that's why this patient had actually 2 nasal surgery prior to this, still can't breathe, AHI in the 40s, good candidate for hypoglossal. But we did the dome procedure. You can see he's still having his occlusion restored. But it's the combination of this two that's going to make this work. Okay. And this is another good patient example I wanted to show, where at 1.5 volts, it was too stimulating. Patient didn't like it. And, to bring it down to 0.8 volts, we basically closed his mouth, promoted nasal breathing, and what a humongous change that is. And the patient's able to tolerate their therapy much better. Okay. Please cut me off, by the way, if I run over time. This is a second additional consideration that's very, very important. This is a very, very recent study by Phil Hewitt at Harvard, where looking at, 343 patients. So fulfilling all the criteria that we do know as of now, the negative predictors of a successful response to hypoglossal nerve stimulation is complete oropharyngeal collapse, meaning complete lateral pharyngeal wall collapse. So what we don't like is beyond the concentric collapse, complete lateral pharyngeal wall collapse is also not giving us very good results from this therapy. Okay, so lateral pharyngeal wall collapse. Now, this is actually not surprising. We were part of this study where we looked at soft tissue surgery. And again, the predictor for failure tends to be tongue-based collapse and also total lateral pharyngeal wall collapse. Previously in Phil's paper, he also noted that a positive predictor of a good result are those with isolated tongue collapse, but the lateral pharyngeal wall and the velum is stable. Okay. Now, years ago, we looked at this and we noted that indeed, okay, lateral pharyngeal wall closure in sleep MRI, so non-drug induced, does correlate with more severe disease. And this is what my fellow last year, Courtney, she's now an attending sleep surgeon at Mount Sinai in New York, and looked at predictors of voltage amplitude. So who are those who need a higher voltage to make this work? Well, those with complete lateral pharyngeal wall collapse as seen on sleep endoscopy. And as you can imagine, the higher the voltage, the more likely your patient's not going to be able to tolerate the device overnight. Turns out that we already have an answer for this anyways, because the lateral pharyngeal wall is very well addressable, well addressed by MMA surgery, right? So with the movement of the MMA surgery correctly, there is tremendous stabilization of the lateral pharyngeal wall, even in patients who are morbidly obese, as you've seen on the upper right. Okay, so now you're starting to think, okay, so if a patient has complete concentric and lateral pharyngeal wall collapse, you might consider doing this before your hypoglossal nerve stimulation. And this turned out to be quite interesting in our patient population. So we have relapses from MMA surgery in the past. You can see this is so old, we actually did not include the C1. But anyways, inclusion of C1 doesn't make a huge difference. So sometimes if it's difficult to dissect the C1 or wrap around the C1, it might be okay to forget about it and not cause too much retraction injury to the nerve. But the idea is that not only with relapse, but with patients with AHI, as high as 149, you can bring it down, right, to criteria with an MMA surgery followed by hypoglossal nerve stimulation. The elder adults seem to do very, very well as well with hypoglossal nerve stim, so that is great. And they are not usually typical candidates for other forms of sleep surgery. These are just some of our cohort. So these are the MMA relapses followed by hypoglossal, very successful. These are the ones where we plan MMA plus hypoglossal, very, very successful. And that's why, again, as you can look at this, all of this works on the continuum, and you have we have the entire playbook now with us to improve outcome for all patients. And to close and to end with this, again, we just had a great talk on pediatric adolescent sleep apnea, and I'm fully, in agreement with treating patients as young as possible before any of the comorbidities occur, because, again, once they're older, again, we have to do, combination therapy and just much more treatment in order to get them to a good spot. And I promised you I would throw a curveball at the end of this, and this is research work with my current fellow, one of my current fellows, Tomas, who did his most recent research work at Johns Hopkins, looking at this interesting behavior using ultrasound is looking at stimulation and how even if you do everything just quite right, sometimes the tongue does pull forward, but then it retracts backwards and upwards. And so the real question now becomes, is pure stimulation of the protruser branches really the answer for everybody? And so I think there's going to be a lot more of this to come in future years. Very much appreciate all the fellows. Hey guys, you can apply to our fellowship if you want to join our team. I would be very, very happy if some of you would be interested to come. I'm also recruiting for postdoc research fellow, and please do consider visiting us again after the pandemic and everything is all over. And just remember why we do this in the end. Restoring the sleep airway health is a gateway to wellness, and I think as surgeons we carry the key. Thank you very much.